Now, from the News Channel 5 network, this is Medical Mondays.
Good Monday evening, everyone, and welcome to Medical Monday. We are kicking off Medical Monday once again, and we're so happy you're here with us today. If you have back pain, I have two excellent experts in the field that are here to help you out tonight. So go ahead and jump on the line. The number is on your screen, 615-737-PLUS, or that's 7587. That is the number to call tonight. And as always, I promise we will get through as many calls as we can tonight. So if you have back pain, want to talk to the docs, this is your chance to do it for free. You can't beat that. And the doctors I have with me, Dr. Elalayli and also Dr. Patel, both from Summit Medical Center. You have your own practice out in Hermitage. And you guys are just going to help us explain everything about back pain over the next hour. We got a long time to delve into it. And it really is something that so many people deal with, and it affects everything you do because it's your back. I mean, even when you're sleeping, it can affect that, for heaven's sakes. What do you guys see as the main complaints when people come into your office? Dr. Elalayli?
So back pain obviously is a very common problem. Probably 80% of adults will get back pain at some point in their lifetime. Lots of possible causes, some of which are very minor and temporary, some of which can be fairly severe. So we do see a lot of patients that come see us. Usually they'll have seen their primary care physician first, had some treatment, not had a lot of success, and then so they come see us for an expert opinion.
You both are surgeons. Dr. Patel, when you see patients, how often does that result in surgery?
So we're both fairly conservative. Our goal is to actually avoid surgery if we can. The first and foremost is to try to figure out what the diagnosis is. Oftentimes it can be challenging. We'll start with taking a history, doing a physical exam. We'll possibly order x-rays and possible other fancier tests like an MRI. And so what we first try to figure out is what is the diagnosis, and then we'll go through a checklist of what we call conservative options. So those are non-surgical options that can array from medications to physical therapy. Some folks try chiropractic care, and sometimes we even do injections. And if somebody fails all of the conservative treatment and we think they're a candidate, we would consider surgery as a last option.
Why is surgery that last option?
Well, of course, there's always risk with surgery, and most patients that come in with back pain or neck pain will actually improve with conservative treatment. So we just have to guide them towards that treatment, and we start as conservative as possible. That might be a simple anti-inflammatory to more aggressive treatments such as injections. But there is risk to surgery, so we like to avoid it if we can.
We have a spine behind us here. Can you guys give us a kind of a spine 101? Walk me through it because it looks pretty complicated, and you know, it supports our whole body, right?
Yeah, it does. So the spine is made up of the vertebrae, which are the bones that stack up on top of each other. In between are the disc spaces, which are the cushions. And then on the back side, you have the joints that connect all the vertebrae together. These yellow things you see are the nerves that come out at each level. These nerves are what help us operate our arms and our legs, give us sensation, and give us the source of pain too. So the spine, basically, it's fairly complex. But if you look at it, you know, you try to break it down. What we do is try to figure out what the source of the pain is, kind of zero in on it, and then find ways to get people better.
And so very important, not just because it's supporting the body, but your spinal cord is right through the middle there, and that's where all the nerves are going to shoot out of, right? So we're talking about every system in your body.
It is. So the spine, basically the brain, and then the spinal cord and all the nerves, basically that's the control center of everything, like you said. And if you look at the spine, I mean, it's substantial. There's bone kind of all around. It's very protective, sort of as an evolutionary thing. And so you see kind of the nerves kind of squeaking out through these little holes. So it is. It's fairly complex, and it's obviously a very important part of the body.
Dr. Patel, you were telling me before we went on, you guys kind of look at pain in two different areas. You have the neck pain and you have the back pain. Can you tell me a little bit about that?
Yeah, so we break the spine up actually into three categories. Your cervical, or your neck, which are the top 7 vertebrae, and then the middle is the thoracic, which have 12 vertebrae, and then the lumbar, or low back, is 5 vertebrae. We see most of our problems in the cervical and the lumbar because there's a lot more motion that's occurring in your neck and your low back. Your thoracic doesn't move as much, so you don't have as many problems. So we try to first isolate the pain to a certain location so we can hone down on the exact diagnosis.
What is the correct shape of a spine? When you take an x-ray, what are you looking for?
Yeah, so it's an S-shaped curve, so you're looking at it from a side view, and then you're looking front to back view. And a front to back, the spine should be straight. If you have a curvature, it's known as a scoliosis. When you look at it from a side view, it's sort of an S-shaped curve. So in the upper cervical, you have a sway this way, which we call lordosis. And then in the thoracic, you have kyphosis. In some of our elderly patients, they have accentuation of the kyphosis where they're actually tipped forward. And in the lumbar, you also have down the low back a lordosis. So it's an inward curve up and at the bottom, and what we call a kyphosis in the middle.
You often hear people saying, I have a slipped disc or I have a herniated disc. What does that mean, Dr. Elalayli?
Well, unfortunately, a lot of people use these terms interchangeably, and they can be told by somebody they have something which they really don't have. But when we talk about like a bulging disc or a herniated disc or a ruptured disc, we could be talking about the exact same thing. Okay, just to different degrees. And then a slipped disc, I think a lot of people, they hear that and they're probably misdiagnosed. I mean, if I was going to think of a slipped disc, I'd probably think of one vertebrae that was actually slipped on another one, which we call spondylolisthesis. There's a few different causes for that, the most common of which is degenerative or arthritis, but it also can be a developmental problem or something you get as you age or as a child.
Would you say most of your patients are older just because the wear and the tear on the back leads to pain, or is it kind of all across the board?
So it depends on the diagnosis. I think when you're talking about a herniated disc, that tends to be in the younger patient population, 20 to 50-year-olds, typically more active patients. When you're talking about spinal stenosis or degeneration, that tends to be in the older population, sort of the baby boomers. We're seeing a lot more patients with that diagnosis. And so depending on the diagnosis would then kind of break down at the age group.
Okay, I want to ask you, what are the best things that we can do for our back health or our spine health?
There's a lot you can do from a preventative point of view, which is like exercise, losing weight, not smoking. There's some lifestyle things that definitely can affect your back. A lot of people want a quick shortcut solution, which isn't always an option. So really a lot of it is prevention and really common sense things to keep your spine healthy. Same things you do for the rest of your body to maintain health. It affects your back as well.
Obviously, I know smoking is terrible for you, but how does that affect your back health?
Smoking is linked to disc degeneration and other problems. You know, smoking causes a lot of issues. People don't normally connect it to back issues, but back issues included. So when we see people that smoke 1 or 2 packs a day, they do that for many years, it leads to a lot of consequences, including in the spine.
So many of us sit at our computers all day long, or especially kids, like this all day long. Are you seeing that cause huge problems?
We talk about it as to whether or not texting and looking down on your phone is actually going to cause a structural problem. I still think is unknown. There's increased loads in the disc based on research. Whether that causes problems long term, I think is still unknown. But proper ergonomics at work is very important. So having the monitor at the appropriate height, having a back with the appropriate lordosis, so it can account for these curves in your back, are definitely important. Some people now are having sit-down, stand-up desks, so they can take breaks, they can stand up, so they're not in a seated position the entire day. So it definitely makes a difference.
What is the number one thing you would tell people if they want to have a great back for their entire life? What do they need to do? Is there one thing?
I don't think there's any one thing. I mean, some of it is probably genetic. Some of it is related to injuries that maybe were out of their control, like a slip and fall or a car accident or something. But generally speaking, I think it's maintaining, an exercise program for your back, losing weight if you need to lose weight, not smoking. A lot of lifestyle things I think can keep your spine healthy.
And I know pregnancy can bring on a lot of back trouble, a lot of back aches and pains, and severe pain for some people. What do you tell pregnant women? Because obviously it's not a condition that's going to last forever, but if you're in that pain, you want to get out of it.
Yeah, I mean, it's typically transient. It usually goes away. You're carrying that extra weight on the front, and your spine is essentially the back of the crane, so it's constantly fighting that weight that's pulling you forward. And we just support the women that are pregnant that have back pain. Mostly they can take an anti-inflammatory and really just try to get them through their 9 months, and usually when they deliver, their back pain usually subsides. So not a lot to do other than just treat their symptoms throughout the pregnancy.
All right, let's jump to the phone lines. We have John on the line. John, thanks for being part of Medical Mondays. What's your question today?
I have spinal degenerative disease, and it's in my number 5 and number 2 disc in the back of my neck. And I was diagnosed probably 3 years ago, and they told me then that I was probably going to have surgery. And the pain really, really never goes away, but I've managed to hold a job and keep it together. But in these winter months, it gets so cold, and it's just an ache. It's just, what can I do for that? And do I really have to do surgery? I've heard that you're down for 6 months after this type of surgery.
Okay,
and
well, John,
I'm just curious as to what I should do to ease this pain.
Yeah, it's good always to have a second opinion. Doctors, what do you think?
Well, John, thank you for calling. If they told you you had cervical degenerative disc disease, that means the cushion between the bones is starting to wear out, and it can be a source of pain for people. There are a lot of conservative treatment options. You didn't really describe what your symptoms were. I'm imagining you have some neck pain. If you're having pain radiating to your arms or numbness or weakness, you should get an MRI if you haven't yet. Surgery generally is optional. If they told you you have to have surgery, that's typically not the case unless there's a neurologic problem. And then you talk about weather-related changes, which are common for people. The changes in the pressure, the changes in the weather can sometimes stir things up. So it's kind of a limited amount of information. I'd want a little bit more history, a good physical examination, and look at your pictures. But you probably have a lot of treatment options that you haven't yet explored.
Well, that's some good news.
Yeah.
That's some good news. Okay. On that note, we are going to take a quick break. More of your phone calls right after the break. We're talking Back Pain 101 today. Stay with us. Welcome back to Medical Monday. Today's topic is Back Pain 101. I have two doctors here with me to help educate all of us about back pain and what you can do about it. Dr. Patel and also Dr. Elalayli. They have a private practice in the Summit Medical Center out in Hermitage. And we've got lots of great calls. I want to get right to Jay. Jay, thanks for holding on during the commercial break. What's your question? Are you with us, Jay?
This is Todd.
Oh, hi, Todd. I'm sorry. Todd, go ahead. Jay, hang on. I know you're on the line, too. Todd, go ahead with your question.
Oh, absolutely. I have a couple of daughters, 10 and 12, and they're playing a lot of sports. It seems like much more than I ever did when I was a kid. And I'm just curious if there's going to be any type of long-term effect on their bodies. And, since I don't know how much studies have been done on all this activity nowadays with all these small children.
What kind of sports are they playing?
Soccer, mostly soccer, and then track and field. And I'm just wondering if 10 years old and 12 years old is too early and too much on their joints at this young age.
Great question. All right, doctors, what do you think?
Thanks for the question, Todd. At that age and with those sports, I don't think there's been any data to reflect that there's going to be any long-term injuries to those girls. They're non-contact sports. It's very rare to develop a structural abnormality that would lead to something like surgery down the road because a 10-year-old is playing soccer or a 12-year-old is performing gymnastics. I would say 99% of children that we see in the office, it's usually a soft tissue injury, a sprain or a strain. We sometimes will order an x-ray or a CAT scan or MRI, and almost always it comes back normal. But I don't think there's any data to reflect that kids performing sports at earlier ages leads to issues down the road.
Let's talk about football. Such a concern. We see so many stories about it and the concussions and the hard hit impacts. What are your thoughts about it? What research have you seen?
So football obviously is the big headline getter right now, especially because of concussions. We know there's an inherent risk to playing a contact sport like that, despite the helmets and all the safety things that they do. I think as parents, you have to accept a certain amount of risk when you participate, and you have to rely on the increased awareness now, where I think the coaching staff, the physical trainers, they're all paying attention to concussion signs and symptoms. It's more obvious when somebody falls and hurts their knee and limp off the field. But if they kind of get a little fuzzy or a little, goofy after being hit, they really need to come off the field and get assessed before they can play again.
During football season, do you have a stream of football players coming in with back issues from being crunched in that tackle, or not something you usually see?
We do. So it's not uncommon to see acute injuries. It's not uncommon to see particular types of injuries that affect the lower back. There's certain problems that football linemen are prone to get because of the constant impacts and the extension that they get when they get hit. So it's not at all uncommon to see 15 and 16-year-old high school football players that have a back problem that needs to be treated.
Are these types of things that they can recover from and go on and not have back pain later in life, or are these things that might plague them long term?
So no, you definitely can recover. The important thing is not to ignore it and not to just fight through it and play through it, in which case it can become a much more chronic, difficult thing. So at the early onset, it's better to be checked out, be evaluated. Once you're evaluated, then recommendations can be made.
Okay. Good information there. Now let's go to Jay. Hi, Jay. Thank you for your call tonight.
Good evening. Thanks for taking my call.
No problem. What's your question?
Doctors, I was wondering, I had a question. I'm in my mid-40s, and I've had a pretty good back, but I do work out and do run. I was wanting to know about the teeter, you know, the device that you get in and get upside down, and it's supposed to stretch you out. And I just wondered what your thoughts are for that. Thank you.
All right, thank you, Jay. Hey, good question. We've all seen that infomercial where they tip you back, you're supposed to stretch out. What is it? What's the purpose, and does it work?
Basically, that's an inversion table. The idea behind an inversion table is basically to try to get some traction on your back. The way our back works is with gravity, when we're upright, there's a lot of compression sort of on the discs. And that compression then kind of squeezes the disc, and then the fluid kind of maybe seeps out, or maybe the disc bulges. So if you invert yourself and you let gravity kind of work for you, then it kind of pulls some negative pressure on the disc, maybe pulls fluid into it. And if the disc is bulging, maybe pulls it back in. My experience with inversion is some patients really like it and some people don't. Some don't tolerate, you know, kind of being upside down a little bit, kind of affects their head in that. I can tell you, if you have a friend that has an inversion table, I would try one maybe before buying it. Or if you're not sure, you could probably find a used one on Craigslist or find one with money-back guarantee. There's not a whole lot of science behind it, but in theory, for certain people with certain problems, it's probably worth a try.
How long do you stay on these things? I mean, what's safe?
That's a really good question. I think it's a matter of a few minutes.
Oh, okay.
So you're not going to stay inverted for like an hour.
Right.
I think a few minutes and see how it feels. Also, the amount that you invert is adjustable just depending on your tolerance and your preference.
How often do you see, or maybe you hear, of people having back pain and switching their shoes or getting orthotics? Does that tend to help? Yay or nay?
Yeah, I mean, I think it does. You know, I think it's a complex diagnosis to figure out if a gait disturbance from a foot issue is causing back pain. But I think if somebody has a leg length discrepancy, if they're flat-footed, and there's a lot of other foot disorders, will relay the pathology to your knees, your hips, and your spine. I had a patient recently simply get an insert, and I think a decade of back pain went away, and she was so happy.
Wow.
And so definitely, I think correcting the abnormality all the way down to the foot and ankle can help your back pain.
How do you discover that, though? If they come into your office, they've had a decade worth of back pain, and you all of a sudden say, let's get an insert in your shoe and see if that helps. What went into that discovery?
So I can't take credit for that particular diagnosis. And so at our office, we have specialists in the foot and ankle, all the way up to the spine. So if we look at the spine and structurally we feel like the spine is normal, and we evaluate the feet and we see an abnormality, whether it be a flat foot or if we think they have a leg length discrepancy, we can refer them to one of our partners.
Right.
Sometimes we'll refer them to an orthotist or the physical therapist, and they can help us make that diagnosis as well. So it's sort of a team effort when it comes to multiple different areas causing pain.
Okay, good information. Let's jump back to the phones. Arlene's been waiting ever so patiently. Thank you, Arlene. What's your question?
My question is that last Monday I had an epidural because I've been in a constant pain, excruciating pain.
Arlene, are you speaking directly into your phone? We can barely hear you.
Oh.
There you go. Okay, now try now.
Okay, thank you. Anyway, the MRI showed that all 5 of my lumbar discs are either moderately or severely bulged, plus there is stenosis. I do have degenerative disc disease. The thing is that the epidural has not helped me that much. I'm still in pain. I'm not in as much pain. Also, I just wondered, none of the meds that have been given to me are touching the pain. And I just wondered what my options are now.
That can be a tough one.
That can be a tough one. So, I mean, what Arlene seems to be describing is diffuse arthritis throughout her back, which can be challenging. If your entire back is arthritic, it's tough to figure out where the pain is coming from. So what we would typically do is look at that MRI after doing a history and physical, look at where her symptoms are coming from, and try to narrow it down to maybe a couple levels or one level of the spine. And then we would focus an epidural steroid injection at that level. So a couple things could be going on. Either she got the epidural at maybe not the appropriate level, so it's not as effective. And in a bunch of people, epidurals don't work like we want them to. And unfortunately, sometimes we have to go on to surgery. But it definitely sounds like a complex situation where every disc has an abnormality. I'm assuming she's a little bit older. And so we have to really figure out and hone down where the pain's coming from, really to help those kind of people.
Can you see arthritis on an MRI?
Yeah, so every one of our spines is going to be arthritic as we age, 100%.
What is arthritis? Let's back up just a little bit. What is it?
So arthritis generically is the wear and tear of a joint.
Okay.
And so the spine, we use millions of cycles over our lifetime, and all that motion over time, loading of weight, laborers that are working hard, athletes, as we alluded to, the spine essentially begins to break down. And so arthritis is just good old-fashioned wear and tear.
Okay.
And to a certain degree, we all develop it as we age. We see it, unfortunately, prematurely in some patients in their 40s and 50s, but it's a breakdown essentially of the joint.
Okay. And so let's fast forward to where we were. Do you see it on the MRI or not?
We do, yeah. So we'll see it on x-rays, and then the MRI would be very sensitive, not only look at the arthritis, but the MRI really shows us the nerve structures and the discs. But plain old x-rays in the office can show us the arthritis as well.
But it's not something, I used to think arthritis was something you could go in and, okay, let's rotor-rooter that out and you'll be fine. That's not how it works, is it?
Not precisely, no, but sometimes if there is arthritis and bone spurs that are, for example, pinching a nerve and causing pain, you can go in there and remove the arthritis and bone spurs and get pain relief that way. So it's not quite that simple, but arthritis can be treated, and it can be treated sometimes surgically.
Okay, very good. On that note, we're going to take a quick break. When we come back, more of your questions. So if you have a question, we have a few phone lines open. Go ahead and give us a call during the break. The number is 615-737+. That's the number to call. We're coming right back. Welcome back to Medical Monday. Our topic tonight, Back Pain 101. Let me introduce you to our guests. If you're just joining us, Dr. Elalayli, also Dr. Patel. They own a private practice in the Summit Medical Center out in Hermitage. I've had a hard time saying that. I have no idea why. But I promised we would get to as many calls as we can, and we've had lots of them. Kathleen's been hanging with us. Kathleen, what's your question tonight?
Hi. Yeah, my question is this. I have a lower L1 deteriorating, L4 and 5 deteriorating, and a bulging disc, L7 deteriorating. I had the L4 and 5 bulge. I had a shot injected into it of steroids back in 2008. And I went today because I have neuropathy, and I went today back to the doctors here in Tennessee because I have massive pain going on, and they're telling me that all this deterioration is sending me to a neurologist.
They're sending you to a neurologist? Is that what you said?
Yes.
Okay.
Mm-hmm. And I want to know what I can do that avoids any type of surgery whatsoever.
Okay. You want to avoid surgery. Okay, Kathleen, I'll put you on hold to listen to your television.
Kathleen, thanks for your call. So it sounds like you've got some problems with your lumbar spine, your lower back, deteriorating discs, which we all get as we get older, maybe a bulging disc. I think the key is to focus in on the source of pain. You said you had an injection in the past. Injections are a common treatment option for degenerative disc disease, for bulging discs, pinched nerves. You said you also have some neuropathy, so it sounds like a lot of different things that could be a source of pain.
What is neuropathy?
So neuropathy is when people have like numbness or burning in their legs, decreased sensation. It's common in diabetics, but there's a lot of other causes. So I think the focus for you, especially since this has been going on for a long time and you want to avoid surgery, would to start with taking a really detailed history and physical, maybe some imaging studies, x-rays, MRI, try to pinpoint what the pain generator is, and then try to focus the treatment on your pain generator and try to get some relief. Not everybody that has pain is even a surgical candidate, so you really want to focus on the non-surgical treatment. Honestly, we need more information to really be able to get down on that and try to get it,
Sometimes is it worth, she said, several years ago she had an injection. Sometimes is it worth kind of starting over from square one to say, okay, let's take a look at this again?
I would. So that's where the history and, how did the injection work? What other treatment options have you tried? How recent is the imaging? If there hasn't been any recent imaging, or if the symptoms are changing, updated imaging would be helpful. Maybe there's an entirely new problem that we're unaware of.
Yeah, because it's been several years. Age happens to all of us, right? All right, so hopefully that helps just a little bit. Let's jump to Robert's on the phone. Robert, good evening. What's your question?
My question is, 20 years ago, I picked up something pretty heavy and hurt my lower back, right around my belt line. Since then, I've dealt with pretty much constant pain. I can pick up something just as, it doesn't have to be anything heavy. It can be a leaf or just anything in a certain way I move, it's like a pinched nerve is what it feels like. It's just severe. It may put me out of work for 2 or 3 days. I've looked up different things, talked to different people. I've had some people talk to me about maybe changing my diet.
Have you gone to the doctor, Robert?
No, I haven't.
Why not?
Well, I can't afford to go to the doctor, honestly.
Yeah.
I've talked to people. People have told me about an inversion table, and I'm just trying to get some knowledge on what I can do myself to ease up the pain a little bit.
Okay, Robert, I'm going to put you on hold so you can listen to the doctors, okay?
Thank you.
All right, thank you for calling in. Dr. Patel, what is your suggestion? That's a tough spot to be in. You're in pain, but you can't afford to go to the doctor.
Yeah, I mean, we'd love to get them in front of us and, do a history and physical, get an x-ray. I mean, I quite often hear patients that have a lifting episode 20 years ago, and then over the course of 2 decades, they get progressively worsening back pain. In my experience, what these patients typically have is the disc that's probably degenerating. It creates back pain, then the nerves get pinched. It can create that nerve pain you might have been describing. Things that he could do on his own would be the exercise, the core strengthening. Oftentimes people take simple anti-inflammatories if there's not a reason not to. But certain conditions, unfortunately, people can't control themselves. If he is at a point of degeneration or pinching of a nerve, he may need help. He may need us to take a look and give him some advice that he might not be able to take care of on his own. So that's challenging because we'd love to see what his problem is. We're just kind of guessing otherwise.
Right. When you say pinched nerve, as we look at the spine, if you have a pinched nerve, does that mean the disc has deteriorated in there and like the bone is sitting on the nerve? Is that what it is?
Yeah, I mean, essentially you described it. So there's 2 common reasons you can get a pinched nerve. The first is if you have a disc herniation. I'm not sure if this is coming across well on television, but this red is actually a ruptured disc where you can see what it's doing there.
Yeah.
It's hitting the yellow. And so that nerve, everywhere that nerve goes is going to hurt. And so that would be a disc herniation. The other way you can get the same phenomenon is if that disc degenerates and collapses, this nerve indirectly gets squished as well. And so those are 2 different ways. One's a herniation, one's degeneration, but both are creating a pinching with pain down the buttock and down the leg.
Yeah, so what do you do?
So for a disc herniation patient, if all the conservative treatments are exhausted, we talked about therapy, medications, epidural shots. Surgically, that is generally relatively simple. So that's typically a 45-minute outpatient surgery, usually through a small 1-inch incision. Patients can generally go home the same day. And typically, if we get the offending ruptured disc out, most of our patients are extremely happy because that sharp, searing buttock and leg pain is gone.
Do you notice it immediately? I mean, do they know, oh, this worked?
Typically, these people wake up and are very happy.
Wow.
If we've done our job right and their body's responding right, typically their pain goes away. Now, they may still have some residual numbness, a little bit of weakness, but they're happy that that severe sciatic pain is gone.
Okay. Let's talk about a more involved surgery, the cervical disc replacement, which is kind of new, I mean, in relative terms, right, Dr. Elalayli?
It is. So the traditional surgery that's been done is to do a fusion. So if somebody's got a bad disc and they need surgery, especially when it involves the cervical spine, you actually go in and remove the disc, which is the problem, but now you have a new problem because the disc isn't there anymore.
Right.
So they would take a piece of bone graft, or we would take a piece of bone graft, put it where the disc was, then a plate and screws to hold it together and fuse it. Now that would fix the immediate problem, but it created an entirely new problem because it made a part of your spine stiff, it doesn't move anymore, and could lead to further surgery down the road because it puts more stress at other levels. So the idea with cervical disc replacement is instead of removing the disc and then fusing it together, you put an artificial disc in, which allows motion, so it preserves your motion, so you're still able to move good, puts less stress on the discs above and below, and then you have less need for future surgery, and hopefully you do better sort of long term.
We have a video animation, so Dr. Patel, if you can kind of walk me through what we're about to see, and this deals with the cervical disc replacement versus the fusion. Let's roll that video if we can, and tell me what we're watching.
Yeah, so on the left side of the screen, as Dr. Elalayli alluded to, is a disc replacement, and so there are devices in there that are maintaining motion. On the right side is the fusion. You can see a plate, but looking above and below the fusion where it's red, those discs are seeing extra pressure, and those are the discs that we fear can degenerate, leading to more surgery. So on the left side, you can see the artificial disc, and on the right side, you see the plate. And the fear, again, is that stiffness leads to issues down the road over the next 5 to 10 years that then will lead to a second or third surgery.
And that can't ever be a good thing when you have to continue to do surgery.
Correct.
Yeah. And even, I mean, it just kind of makes sense. If you're putting a plate on some spine, you know, on a portion of your spine, you're not going to have the movement there, right?
Yeah, correct. And so functionally, people develop a little bit of stiffness from actually fusing, but our bigger fear is this patient going to return in a few years and we're going to get another extra MRI and the level above, which previously was okay, has now worn out or is now ruptured. And so the goal of the artificial disc replacement is to prevent or decrease the incidence of patients coming back and needing more surgery.
Well, let's talk about the success of this relatively new. I think, what was it, FDA approved in 2007 maybe, I think, if I read right. But so, relatively new. What are you seeing success-wise?
Yeah, so this, the particular one that Dr. Elalayli and I are using was FDA approved in 2013.
Okay.
They started implanting it in 2006.
Okay.
And so we don't have 30, 40, 50-year data like we do with knee and hip replacements, but the short-term data, which is over the last 60 months or so, is very optimistic. We're showing at least as successful as fusion, and in certain criteria, better.
What's better?
So the level of adjacent degeneration in the short go is less. Patients are actually returning to work quicker. In a few of the studies, patients return to work up to 3 weeks before a similar patient with a fusion.
Oh.
And so those are the two big improvements we're seeing, is really the adjacent level degeneration and functionally returning to work quicker.
Dr. Elalayli, when you're looking at a patient and you say, should we do A or should we do B, who makes a good disc replacement candidate?
So generally younger patients, it makes sense since you're younger and you want to try to preserve your normal anatomy as much as you can. The only time that you really can't do a disc replacement is if you have a lot of arthritis in those joints, then you don't want to preserve motion, because arthritic joints keeping, you know, if they keep moving, can be an ongoing source of pain. But assuming the joints are healthy and you're just removing that disc, then generally speaking, a disc replacement is an option.
What follows this surgery when we're talking rehab or downtime? What are your patients going through?
So typically, probably about a 1-hour outpatient surgery. We have to restrict some activities. You don't have to wear a neck collar. We used to do that with people when we did fusions in the past. You don't need to wear a collar. We usually will keep you off work for a couple of weeks. You're probably not driving a car, maybe for a week or two, just depending on how much pain medicine you're using. But most people are able to get back to work within a few weeks. They usually have an immediate improvement in the pain that necessitated the surgery, but we want to take it easy for a few weeks and just let people recover.
And the pain reduction should be immediate, or?
It's usually immediate. So people usually will have pain that's shooting down their arm, numbness, weakness, things like that. So typically a patient will wake up and say the arm pain is immediately gone. They have the surgery pain, but that gets better pretty quickly.
Okay, let's jump back to the phone lines real quick. We have Sandy on the line. Sandy, thanks for being part of Medical Monday. What's your question?
Yes, I'm scheduled for surgery, an ADCS, and he was talking about it being, you could be stiff. Would that leave me stiff on the neck?
That's a good question. So the ACDF, that's the fusion surgery that we're talking about in the neck. Now, if you have a normal disc that's moving and then you fuse it together, if it's just one disc being fused, you could lose 5 to 10% of your normal neck motion. Now, you might have already lost that motion because maybe that disc is degenerated, maybe those joints are bad, maybe your pain limits your motion. But generally speaking, a fusion is going to restrict your motion forever.
And how much motion are we talking about? Can you show me how? I mean, what would be the difference?
Well, if you imagine what your normal motion is, that you could rotate and then look over your shoulder, and then for each disc you fuse, imagine maybe 5 to 10% less. So if you fuse 2 or 3 discs, you might only get halfway there. If you fuse just one disc, it may not be very noticeable. So it really depends on how extensive the surgery is.
Okay, when we were talking, I mean, is this something that you think she should get a second opinion, or is this something that may be pretty typical, or just you don't know because you don't know her case?
Well, we don't know the case. A fusion is still more commonly done than a disc replacement, and the success rate with a fusion in the right patient is still greater than 90%. So it may be the right surgery for you. Without actually seeing you and seeing the images, we can't really give an opinion. Assuming the doctor that saw you, reviewed the images and gave you a good opinion, it might be the right surgery for you.
Okay, let's jump to Paul. He's on the line. Paul, good evening to you. What's your question?
I have arthritis in my lower back, and I have some trouble walking. Some days it's worse, some days it's better. And I was just kind of wondering if there's anything I can do to kind of help alleviate the pain.
Yeah. Okay. Let's see what Dr. Patel has to say. You know, people just want to be out of pain. You know, this is why they come into the office.
So what that reminds me of potentially is lumbar stenosis. So the classic patient we see with lumbar stenosis, and what stenosis in Greek means is choking. So the spinal nerves are getting choked, and they're getting choked from arthritis. So there's a constriction or narrowing. What the typical patient complains to us all the time is they come in, they have difficulty standing or walking, they can't go to the grocery store with their husband or wife, they have to sit down frequently. Leaning on a shopping cart helps these patients, and so what they're having is pain that starts in their back, goes into their butt, and down their legs, and that's because of the narrowing or choking of the nerves from the arthritis. And so when we see those patients, typically we'll order an MRI. We'll diagnose that condition. We'll often try an epidural steroid injection or something simple. If nothing works, there are surgeries that predictably can improve those patients. So we go in and essentially open up that choking of the nerves, open up the space. Usually they get some immediate improvement in that buttock and leg pain. They're able to finally walk longer distances, enjoy their life typically. So there is a solution if that indeed is what he's describing. But we see that very commonly.
And nerves regenerate, don't they? I mean,
so these peripheral nerves that we're talking about, they do. They have a potential to heal. Your central nervous system, your spinal cord, and your brain have less of a potential to heal if they're damaged. But the nerves in the low back, which are known as peripheral nerves, sure, after we decompress them, and it may take some time, but usually the numbness gets better, the pain gets better quickly. But they do have a potential to heal.
Okay, very good. We're going to take another quick break. We've got lots of folks to get to, so stay with us, hang in there. We're going to get to you right after the break. Welcome back to Medical Monday. We're talking Back Pain 101, getting lots of calls answered today. We're going to jump right back to it. Anna's been patiently waiting. Anna, what is your question tonight?
Yes, my question is, I've had all of the above that you've been talking about. As the moment, though, I'm talking about the sciatica nerve burning down your left leg. And I want to know if that is attached to the sixth vertebrae in the low lumbar.
Okay. Anna, go ahead and listen to your TV, and let's see what Dr. Elalayli says.
Well, thank you for your question. So sciatica is a common term for pain that radiates down your butt and into your leg. You can get it in just one leg or both legs. It can be down the back of the leg commonly. That nerve, although once it's in your butt and leg, we call it the sciatic nerve, it's made up of nerves that start in your lower back. So these little nerves here, they will connect together, and then they go down your buttock and your leg and form the sciatic nerve. So if you've got sciatica, the assumption is that that nerve is being pinched somewhere in here.
Sure.
And if we can identify the source of where it's being pinched, then we can usually find some ways to treat you and get you better.
This is pretty common because I hear people talk about it, especially pregnant women.
Very common.
Yeah.
So you can have back pain with or without sciatica, and you can have sciatica with or without back pain.
Okay. Is there anything that leads to it, a particular cause?
Lots of causes. So in younger people, more commonly a bulging disc or herniated disc, and then in older people, more common spinal stenosis like Dr. Patel talked about.
And the best way to cure it?
Well, first identify the source. If there's a mechanical compression of that nerve, sometimes surgery is an option to remove that mechanical compression. If it's just nerve irritation, sometimes medication or an epidural steroid injection can be helpful.
Okay. Let's jump to another caller. We have Gary on the line. Gary, good evening. What's your question?
Yeah, I think you may have just answered my question about the sciatica. I stand long enough to shower, and either one or both of my legs will get numb, get that tingling, burning feeling. They get real weak, and I mean, this is just a few minutes on my feet. So I was, yeah, that is sciatica. I think you just answered that. So.
And if someone like Gary or Anna has this problem, I mean, it sounds like it can be pretty easily solved. Is that fair?
Yeah, potentially. I mean, it sounds like he may be describing stenosis because both legs are affected. And so, when they first come to us, we make the diagnosis, and if they fail everything conservatively, oftentimes there's a simple solution. But it all really depends. It's so individualized based on the patient and what we see on their MRI. But if someone's just standing a few minutes and they're having to sit down or they're having to get off their feet, they probably should see a doctor, at least have a evaluation, and we can go from there.
Okay. Dr. Elalayli, you're telling me one thing we really haven't hit on in the last hour was this SI joint pain. What is that? Let's start there.
Right. So the SI joint, that's the sacroiliac joint, which is the joint that connects the spine with the pelvis. We have one on either side, the left and the right, and you can see how close it is to the spine. So it's an often misdiagnosed source of lower back pain. And so these are often the people that will point to their lower back, either left or right, and put their finger on the one spot, says my back really hurts right here. Pain is often worse with sitting. Sometimes you want to lean off of that side because it's painful. Sometimes they give a history of a slip and fall where they land right on it and they injure that joint. So with a good history and examination, we can usually tell, is the SI joint a source of pain or is it the lower back? We've gotten a lot better at doing this now than we were even just a few years ago.
So if it is SI pain, then what?
So the treatment can be focused on the SI joint. Now some of the treatment may be similar, like an SI joint injection. That can be diagnostic. If we inject it and your pain is better, we know we've identified the source of your pain. Physical therapy, medication, injections, activity modification, it's the same treatment basically, just in a different location than the lower back. But there is now some new surgery options that are less invasive with faster recovery periods. So there are options, even surgical, that can help SI joint pain.
And I know you're doing some of those surgeries. Are they successful on the whole?
They can be successful. So usually it's a surgery that takes less than an hour. You can spend one day in the hospital. It's done through an incision just a couple inches long. And we can actually fuse that joint, and that can help your pain. Now the difference is the SI joint doesn't move very much, so by fusing it, you don't limit or lose any of your range of motion. So it's not such a bad procedure to do to help people with pain.
You were telling me that this doesn't often, not every doctor thinks of this though, when a patient comes in and says, I've got pain right here. Why is it skipped over?
No, even when I trained, we virtually never spoke about it, and I think one of the reasons we didn't talk about it much is because we didn't have a lot of good treatment options for it. It's really just in the last few years that the idea of a less invasive way, surgery-wise, to fix the problem has become apparent, that we've become better really at diagnosing it. Because before then, even if people had pain from there, we really couldn't have very many treatment options on how to treat it.
When someone comes into your office as a new patient, what can they expect? No matter where their pain may be, where is the examination going to start? What's going to happen?
So the history is the first thing. So we've been doing this long enough where simply talking to a patient, we can often hone down where the symptoms are coming from. So we try to first figure out, is it neck pain, is it thoracic, or is it lumbar? And so once we focus on that, we try to figure out, is it just the neck, or is it just the back, or is the pain radiating down an arm or down a leg? Is there a nerve component to this? Is there a weakness component? Is there numbness? So the history takes place first. We then do a physical exam, try to, again, figure out where these symptoms are coming from. And then typically we'll order x-rays. They're easy, they're inexpensive. We could do it right there in the office. And then depending upon that part of the evaluation, we'll decide, can we send you to some initial conservative treatment, or do we need to order an MRI and get some fancier testing to really look at the spine better?
And when you say conservative treatment, what do you mean by that?
Non-surgical treatment. So all the things we've been talking about tonight, from the medications to the therapy and chiropractic care to the injections.
What about massage? Thoughts on that when it comes to back pain? I see you have a little smirk. What does that mean?
Patients ask all the time, and I think the history that I get from patients is they may get a massage and they feel better for a few hours. If there's like an anatomic reason for that pain, the massage probably would give you some short-term relief, but in the end it's not really a solution to most sort of
back pain, to long-standing.
Temporary relief probably. There's no downside to doing it. But it's probably not the solution to most problems.
May not be a lot of upside to it either. You've mentioned shots and steroid shots or the epidural. When I think epidural, I think maybe labor, like you can't feel half your body, but that's obviously not what a back epidural is. Can you explain that?
So the space we're putting the shot is called the epidural space, and so that's similar in what you were alluding to and what we've been alluding to. And what the pregnant lady that's delivering, she's getting an anesthetic, so she can't feel the lower half of her body, so it's not painful. What we're doing is putting a steroid in, which is a great anti-inflammatory. So all these conditions we're talking about with itis after it, arthritis, you can decrease the symptoms. You're not solving the problem with an epidural steroid shot. In some patients, they can get long-term improvement, but at minimum, you're decreasing the inflammation, and patients feel better. Some patients will have long-term recovery. Some patients will have temporary recovery, and we end up seeing them back to talk about the next steps.
Is it something you do every 6 months, or is it just you see how it goes and who knows?
Yeah, I mean, we have some general rules. Typically, we can do anywhere from 3 to 4 shots in a 6-month period. If you're needing a shot every week, that's probably not your option. But if 2 or 3 shots in a 6-month period is holding your symptoms at bay, and then you need to repeat that another 6 to 12 months, that's probably a reasonable course of action. But if you're needing a shot every few days, then that's probably not your treatment of choice.
We're running short on time, but I do want to know this. We have a lot of new gym warriors after the first of the year, January 1, and people go in, they think they're just, you know, He-Man out there or She-Ra, and they can lift all kinds of weights, and of course that can lead to back injury. What's your word of advice to those folks right now?
I think use some common sense. You know, don't lift too heavy. Some people, you'll see them at the gym, they start to lift too heavy, the form goes bad, and that's where a lot of injuries occur, is just really bad form. So if you can work with a physical trainer early on or get some good advice on how to do it properly, that's a good way to start. But you're right. I mean, anytime that you exert yourself, whether it's at home or at the gym, you're putting yourself at risk of injury.
What about running and that constant pounding? Is that a problem over time? Do you see that with back pain?
Yeah, you know, there's some patients whose bodies are meant to run. Mine's not, and most people aren't. You know, it's just that constant loading of your foot, your ankle, your knee, your hip, and your spine. And so if you're prone to having back pain, hip pain, knee pain, that kind of jarring impact exercising is probably not the best. There's so many non-impact ways, whether it's through an elliptical machine, water, rowing. So if patients enjoy running and they don't have symptoms, we don't tell them not to do it, but if they're constantly coming to us with back pain, hip pain, knee pain, running's probably not best for those patients.
Okay. On that note, we're going to take a quick break. More on Back Pain 101 when we continue. Stay with us. Thank you, as always, for joining us on Medical Monday. If you have a question about your health that you would like answered, there is the number to call. There it is, 615-986-6033. If you would like to get a hold of Dr. Patel or Dr. Elalayli, here's how to do it, gentlemen. How do we get a hold of you guys? Website and phone?
Yeah, absolutely. The website's listed up there, and we would love to hear from you.
AdvancedOrthoandSpine.com, or their number is 615-885-0200. Thank you, gentlemen, so very much. We've learned so much. I'm just starting on what is the spine to the surgeries. It's been very informative.
It was great. Thanks for having us on.
Yeah, thank you. And I know you encourage people, if they're in pain, seek out someone, get some answers, right? It can
Absolutely.
Be easy.
And, you know, 99% of the patients we probably see don't end up having surgery.
That's good news.
So we're here to help you with the diagnosis, guide you along the right treatment, and if all else fails, we're here to possibly consider surgery.
Thank you. Thank you, gentlemen.